Okay, now we're going to look at a few short cases of acute coronary syndromes. Here's case 10. Mrs. O'Leary is an 81-year-old female with a past medical history of diabetes and hypertension. She was in her usual state of health until early this morning when she developed mild shortness of breath and an uncomfortable tightness sensation in her neck, back, and jaw. She has had this sensation for about 1 to 2 hours without relief. She rates the discomfort a 5 of 10 in severity with no aggravating or relieving factors. On physical exam, temperature is 98 degrees Fahrenheit, heart rate is 80 beats a minute, respiratory is 22 per minute. Blood pressure 130 over 80. She appears in mild distress, with diaphoresis and dyspnea. Neck has no bruise, and JV pressure is 7 centimeters. Cardiovascular exam, regular rate and rhythm, normal S1, S2, and S3 is heard. No rubs, clicks, or murmurs. Lungs have faint crackles at the bases. Extremities have 2+ pulses bilaterally and trace edema. Her ECG is as follows. The patient's ECG shows which of the following. Is it A, unstable angina, B, non-ST elevation MI, C, ST elevation MI or STEMI, D, Prinzmetal's angina, or E, pulmonary embolism with right ventricular strain pattern? And the answer is C, ST elevation myocardial infarction or STEMI. So the patient's ECG shows a STEMI, and the decision is made to take the patient emergently to the cardiac catheterization laboratory. In which of the following coronary vessels is the culprit lesion suspected? Is it A, the left main coronary artery, B, the left circumflex coronary artery, C, the left anterior descending coronary artery, D, right coronary artery, or E, diagonal branch? And here is the ECG again. So the answer is the right coronary artery. And if I go back to the ECG, you can see that the ST elevation between lead 2 and lead 3 is much higher in lead 3. So although we can't be 100% certain, chances are that the right coronary artery, which wraps around the back of the AV groove to the right of the heart, that this is most likely the culprit lesion. So a stent is placed in the mid-RCA, and she receives usual standard of care in the CCU post-procedure. The patient continues to do well until 4 days after the procedure, when she becomes tachycardic and confused. The physical exam shows an elderly female in acute distress. Pulses are weak in the extremities, and the heart rate is 120. Blood pressure is 80 over 40, and she is pale and diaphoretic. Cardiovascular exam reveals regular tachycardia and a 4 of 6 severity holosystolic murmur at the left lower sternal border. Based on the examination findings, the patient most likely has A, atrial septal defect, B, ventricular septal defect, C, patent foramen ovale, D, patent ductus arteriosus, or E, acute mitral regurgitation. And the answer is B, ventricular septal defect. And what happens after an acute myocardial infarction is that sometimes different structures like the ventricular septum or the ventricular free wall or even the mitral valve apparatus can become infarcted and structurally fail. Because the right coronary was affected in this case, it would be unlikely that the mitral valve would be affected, and the most likely in this scenario is a ventricular septal defect, since some of the ventricular septum, the blood flow supply, actually comes from a combination of the LAD and the RCA. Based on these examination findings, your best next step is to A, repeat the cardiac catheterization, B, start a pressor support with dobutamine, C, bolus 1 liter of normal saline, D, perform an echocardiogram, or E, emergent cardiothoracic surgery consult? And the answer is emergent cardiothoracic surgery consult. Essentially, this is a life-threatening structural failure of the ventricular septum, and the patient could acutely die if they don't receive immediate treatment for this surgically. So the answer is emergent cardiothoracic surgery consult for potential fixing of this ventricular septal defect. On to case 11. Mr. Wilson is a 65-year-old male with a history of ulcerative colitis and cigarette smoking, who was in his usual state of health until this morning when he developed chest tightness during work. Mr. Wilson describes the pain as 8 of 10 in severity, and it radiates to his back and left arm, and it's worsened with anxiety and improves somewhat with relaxation. The pain has been rather constant and has persisted for about 2 to 3 hours since this morning. On physical exam, temperature is 98, pulse is 90, respiratory 20, and blood pressure 110/68. He has no JV distension, no bruits. The cardiovascular exam shows a regular rate and rhythm, normal S1, S2, no rubs, clicks, or murmurs. The lungs are clear. Abdomen is soft, non-tender, non-distended. The extremities are warm and well perfused. There is no edema, and the ECG shows the following. So your next step is which of the following? A, oral aspirin. B, draw serial troponins. C, administer sublingual nitroglycerin. D, beta blockers. E, high-intensity statin. Or F, all of the above. And the answer is F, all of the above. So the patient had a non-ST elevation MI. You see ST segment depression in many of the leads, but you don't see elevation. And even the ST findings in AVR are not considered ST elevation because AVR is the reverse image of most of the other leads showing a downward and leftward depolarization of the heart. So in this case, we were asking primarily about NSTEMI and what kinds of therapies might be needed in an NSTEMI. And so the guidelines state that cardiac-specific troponin levels should be measured at presentation and at 3 to 6 hours after symptom onset in all patients that present with symptoms consistent with ACS to identify a rising and or falling pattern. Patients with NSTEMI with continuing ischemic pain should receive sublingual nitroglycerin, 0.3 to 0.4 milligrams every 5 minutes for up to 3 doses, after which an assessment should be made about the need for intravenous nitroglycerin if not contraindicated. Oral beta blocker therapy should be initiated within the first 24 hours in patients who do not have any of the following. Number 1, signs of heart failure. 2, evidence of a low output state. And that low output state means that the patient isn't perfusing their organs. Number 3, increased risk of cardiogenic shock. Number 4, or other contraindications to beta blockade. Also, high-intensity statin therapy should be initiated or continued in all patients with NSTEMI and no contraindications.